Hello, everybody from the United States. I'm Dr. Pavlo Stolovitsky, International Coordinator for International Affairs and member of the Board of Directors of the American Academy of Otolaryngology, Head and Neck Surgery and its foundation. It is a great pleasure to welcome you to our second edition of the virtual Global Grand Rounds. This time we are here for a treat with great faculties from all over the world, talking about from UPPP to neurostimulation, the role of otolaryngologists in the treatment of obstructive sleep apnea. To start the program, I'd like to welcome the Executive Vice President and CEO of the American Academy of Otolaryngology, Head and Neck Surgery, Dr. James Denneny.
Thank you, Dr. Stolovitsky. I'd like to welcome all of our attendees around the world to this program on behalf of the American Academy of Otolaryngology, Head and Neck Surgery. Particularly, I'd like to thank Professor Hoermann and Tarabichi, who are IAB President and Chair and Chair-elect, as well as our coordinators, Dr. Stolovitsky and Zaffario, for putting this together, and the work of Elise Swinehart and our own Rebecca Dobbins, who's the head of our international program for doing this. This is our second in the series. The first one we had over 800 attendees, and we have 1,200 or more registered for this, so I'm hoping you'll enjoy this. Before I get on to the program, I'd like to give you some great news we just got this week that our annual meeting, our 125th anniversary meeting in Los Angeles, is going to be a full go. The California state and the county and city of Los Angeles have totally opened Los Angeles up, and our meeting will be, I believe, a fabulous celebration. It will be available virtually as well for those who can't attend. I'd like to introduce one of my good friends and a great leader, Carol R. Bradford, who's our president this year. She's currently the dean at Ohio State, as well as the vice president of the health care center in the whole area. She took control of the academy in October of 2000, right in the height of the pandemic in the United States, and has done a great job leading us through the pandemic to seeing the light at the end of the tunnel while continuing to improve our education and quality programs. Dr. Bradford, would you like to say a few words to our audience? Thank you.
Good morning, and thank you, Dr. Denneny, and certainly your leadership and the entire Academy leaders and staff leadership through this pandemic has truly been extraordinary. It is my sincere pleasure to welcome more than 1,100 or perhaps 1,200 of my colleagues from around the world attending this really important seminal conference. It truly has been a challenging 15 months, and my hope and belief is we are starting to see sustained progress against the global COVID-19 pandemic. It is more important than ever that we come together as a profession to share our knowledge so that we can continue to advance our practice to take on the world's existing health challenges, as well as the future challenges we know await us. The focus of our work is people. If we are not connecting with each other and sharing our knowledge and best practices, how can we fully connect with our patients and bring them the healing that they expect from us? So I encourage all of you to use this time, even if it is virtual, to connect with each other's on the platform, to ask questions of our presenters, to fully engage in the content. I know that the success that we have had at this Grand Rounds Forum will bring us closer to a time when we can all be together physically in person. I really look forward to that day and to talking and seeing and engaging with all of you in person about your practices, your families, and your insights. Thank you for the work you are doing every day to bring healing and hope around the world, and for your participation in this important virtual meeting. Dr. Hoermann and Dr. Tarabichi, thank you, and we look forward to your engaging program. I will now turn it over to Dr. Stolovitsky.
Thank you, Dr. Bradford. Thank you, Dr. Deneni, for your kind introductions. I'd like to also introduce Dr. Mark Zaferio, who is the incoming international coordinator for the Academy, and the members of the International Advisory Board, Professor Muaaz Tarabichi, chair-elect, and Professor Karl Hoermann, the chair of the International Advisory Board, who will be moderating this program. Dr. Hoermann.
Thank you very much, Pablo, all of you for joining this second grand round. And for me, I'm 72 years of age now. It is a great moment in my life because when I was a resident some 45 years ago, nobody in ENT knew about sleep. The only story was snoring and septal deviation or something like that. 30 years ago, we founded the German Interdisciplinary Society of Sleep. And then now we have in this grand round an as high number of participants as in our core business. For example, last time when we spoke about the complications after sinus surgery, which was an excellent first round too. So I want to introduce our first speaker. This is Marina Carrasco from Valencia, Spain. We have to know each other for at least 10 years, which we don't believe if I see this young girl in front of me. But anyway, she is board member of the European Academy of Sleep Medicine and also running the Spanish Society Sleep Group. Is it correct? Yeah.
Yes.
And now please start with your presentation.
Yeah. So thank you very much for your kind introduction, Carl. It's really an honor for me being here. And I would like to thank the American Academy of Otolaryngology, and especially you, Karl Hoermann, Professor Karl Hoermann, for inviting me to share my experience with you. So I'm going to talk about DISE. DISE comes from drug-induced sleep endoscopy, and it's a tool that we are using to see patients that have apnea, sleep apnea or snoring in a state that mimics natural sleep. Because when we usually see them outside the operating room or wherever we do this exploration, the patient is awake and we cannot see snoring or we cannot see the collapse of the upper airway because obviously they are awake. And even though we make them make maneuvers, we cannot see it. So when we see the collapse and we see the snoring, we are really happy, because we think that we are seeing it like it is during the night, but is that so? This is what I want to clarify for you today. So the first is to know if DISE represents natural sleep. This is validity. And we have some hints from all these articles that we have here that it can represent, because if we have a very nice sedation, we don't have snore in the control patients, and the critical closing pressure and the negative effort dependence is equivalent to natural sleep. Also, polysomnographic parameters like apnea index and other oximetry parameters are equal to natural sleep, as well as the muscle tone and these levels. But it does alter sleep architecture, because we cannot have REM sleep. We cannot have REM sleep when we do it with propofol, which is one of the drugs that we mostly use. And in 20 or 15 minutes, that is what usually takes to perform DISE, we cannot achieve REM sleep with the other two drugs that are commonly used. There are dexmedetomidine or midazolam. But what it is important to us is to know if what we are watching is exactly what is going on during natural sleep. And here we have these two articles that have shown us, one with propofol and the other one with midazolam, that what we are watching during DISE is equivalent to natural sleep. So this is good news. Even though this is just a snapshot, we are really representing natural sleep in non-REM sleep. So what about reliability? This is if DISE can be trusted. So I'm going to try to answer all these questions. If there's a good concordance among explorers, if experience is important, if we have a good test-retest reliability, what happens when we do it DISE and then we do, after we do the nasal time, nose surgery. So the first study that was published with big numbers between comparing experienced and unexperienced people watching DISE was this one performed by the Antwerp group. And you can see here the numbers of overall agreement and kappa numbers. And they state that the inter-observer agreement was higher at the tongue base and epiglottis and lowest in the hypopharynx. This is not the bold classification, it's a little bit different, but more quite similar. But you can see that the lowest was at the hypopharynx for both for experienced and non-experienced. But the numbers were greater in the experienced people. So they started talking about the learning curve that was important in DISE. So our group also performed one study discussing about reliability, and we compare a resident with my observations. And you can see here that we had a quite good agreement in everything but the tone base. Epiglottis is a little bit different too, but especially in the tongue base, the agreement was not very high. But we also tried to know what we were going to offer the patient that we were watching the video, what was the idea, the managing plan. And you can see that there was a really high agreement between the resident of me and me. So the managing, even though we were not completely agreed, didn't change that much. And then we have this article performed done in Korea. They use a completely different classification, completely different to both, but they review 100 videos, so they could see many different types of collapse. And their conclusions is their tone base is especially difficult, especially when we are talking about what is going on with the lateral pharyngeal walls in this area. There was a strong agreement in experience and inexperience, just like we showed. So there's not really a learning curve. But where this is important, inexperienced people tend to overlook tone-based obstruction, and they focus on the palate because it's the surgery they are most used to do, more familiar. So when we are talking about reliability, we must keep in mind that we have to be careful between kappa and MATS, because agreement can be good, as you have seen, very high numbers, but kappa can be really low. And this is because kappa penalizes prevalent observations. Then the palate will have worse results. And the more possibilities, the lower the kappa is, meaning that if you have 3 possibilities or 4 possibilities of types of collapse from 0 to 4, is going to have lower numbers of kappa than if you just have 2. Maybe what we are watching and we are seeing is problems with classifications and MATS when we see that it is poor agreement. On the other hand, classifications are essential to compare amongst explorers and different patients and database, but some ENTs don't use them. And I think that when you are talking about one specific patient, maybe just using classification is a little bit confusing, but to know what is going on and just writing down what is going on, it's easier. And there's not a perfect classification, but and also the dynamic and the 3D movement of the upper airway, also the collapse, the secretions, makes it really hard sometimes to decide the type or the degree of the collapse that we are seeing. But this doesn't mean that it's going to be a bad treatment plan. So I don't know how is it in the United States, but in my country, in Spain, sometimes we do DICE and we show the video to the patient and he has to wait several months to go to the operating room to do the treatment because of the waiting list of the health system. And it's important to know that at least for 3 months, the findings don't change. So it's important that what we see stays over at least these 3 months. On the other hand, what we usually do or we can do to be more efficient in the operating room time is to do the DICE just before the nose time of the upper airway surgical plan. And what happens now? Does the collapse change or it doesn't? Well, there are only 2 articles watching this or trying to answer this question, and they are quite contradictory because for the first one, which is the older with 24 patients, it doesn't really change. But in this one with 34 patients and it's prospective and they use the NOHL classification, there is a significant change, especially in the hypopharynx. This is the tone base when we are talking about in the both classification, which is the one I usually do. So we have a decrease in the collapse in the tone base or hypopharynx when we are doing the nose treatment. So this is important that we know, and we should do more research on this to try to answer this question. So the $1 million question is what happens after that? I mean, the results. Does it change surgical plan comparing with awake exploration? And if it does, is it followed by an increased success rate after surgery? Are there any special findings on DICE that could suggest that this patient is going to be a success or failure? Because it's important to the patient to know if he's going to go for surgery, what are their expectations, and that could change the surgical plan, technique that we are going to use, or maybe it promotes multi-level surgery. This is what we are going to try to answer now. And I'm going to be quite quick. Here is this article that we published a couple of years ago, where you can find all the details. Even though it's 2 years old, there's nothing new, really new, so it is quite updated. So the only thing new that came out was this meta-analysis just a few months after this article, reviewing more than 1,000 patients, but there were kids included. And they say that it changed the surgical plan in more than half of the adult patients. It doesn't really change the surgical plan comparing with awake when we are talking about the velopharynx, or it could lower indications, which is not surprising because most of the patients show a velum collapse when we are seeing them. And DICE, what does change is the surgical plan for the tone base and the epiglottis. But here we have to be careful because we know from these articles that not all the collapses in this area need to be treated. So does improve surgical results? Well, there are articles that say it does, some others are completely contrary to that. But so far, no randomized controlled trial has been published. So it's quite difficult to know. Most of the published articles have important bias. So when we see those articles, we have to be very careful with the conclusions and be skeptical. On the other hand, as I say, it's important to know what findings we are seeing on DICE that are going to say to the patient, you are a good candidate for surgery. So these are the articles that talk about this matter. In green, the things that are going to say he's going to be probably a success. In red, the findings that we see that is going to be probably a failure. In blue, the things that are related to the hypoglossal nerve stimulation failures. So if we see a patient with tonsil collapse or AP velum collapse or facial AP tone base collapse, he is going to be a good candidate for our soft tissue surgery. On the other hand, when we see a concentric collapse, complete concentric collapse, or a collapse in the velum with a significant collaboration of the lateral walls, or our pharyngeal wall collapse, tone base collapse, no matter the direction, or epiglottis complete or severe collapse, these patients have a higher rate of probability of being failures. And as we all know, the complete concentric collapse at the velum, or important lateral collapse, or complete collapse at the epiglottis is bad for the success on for the hypoglossal nerve stimulation. So we know that the results after UP3 when the patient has complete concentric collapse are bad, because 81% of them are failures. But on the other hand, there has been published that with limited palatal muscle resection or with the Alianza technique, there is a high probability of success. The article of Mantovani with 84% of success was performed in patients selected that only had complete concentric collapse and were had previous tonsillectomy. So not even the size of the tonsils were important in this group, and they had a very high success rate. In the other technique, the limited palate muscle resection, no patient could improve when they had a partial collapse, but a 75% with a complete collapse. And what do share these two techniques, this removal here in the center of the palate and these stitches here. So maybe this is why they are doing great. On the other hand, we don't know really if DICE promotes or avoids multi-level surgery, because as I already said, not every tone base or epiglottis collapse needs to be treated. Because when there is a complete collapse in the velum, the collapse can change downwards after we do the surgery, of course, if this collapse is solved with the surgery we did. What we know is that if the collapse in the velum is not complete, it doesn't change the collapse that we are seeing downwards. So we always have to think in the fluid dynamics that are very important here in sleep apnea. On the other hand, we have to think that when we are watching, when we are doing DICE, the fibroscope passes through this, and here's what we see. And some patients may have a palate collapse here because the tone base is pushing, and others may have this velopharyngeal collapse, this velum collapse, and it's just the palate alone. So what we do in order to know what is going on is that we always do this maneuver in order to leave the tongue out of the field and know if the palate is obstructing itself or is the tongue that is pushing. So summarizing, DICE represents natural sleep. It's a real snapshot. DICE shows poor to good agreement amongst explorers, but poor agreement doesn't equal to a bad treatment plan. Sometimes it's difficult to interpret what is happening in some patients, especially at the tone base, and maneuvers are essential. DICE might over-indicate tone-based surgery, also might help choosing one velopharyngeal technique over the another, and it may help to explain the patients that are bad candidates for surgery. So thank you very much for your attention, and I will be ready to answer the questions at the end.
Thank you very much, Marina. And I think it best we continue with Maria Suurna from New York City. And Maria, we got to know us from Morocco. I think it was the first time when we met. So she's also an ambassador for sleep around the world, and she is not only a member, but a leading person in the board of the International Surgical Society and for the American Academy. She's the regional advisor of the American Academy for Europe and has helped us a lot connecting, since her roots go back to Estonia, which is definitively a part of Europe. Maria, please start with your presentation.
Thank you so much. Thank you for the kind introduction. Let me just share the screen. I was working a second ago. Hold on just a second. So it's a pleasure to be a part of this global grand rounds, and it's great to see everybody and to connect with the colleagues and from all over the world, and definitely looking forward to seeing everybody in person. And today I'm going to cover a kind of a little bit broader topic that incorporates advances and individualized approach in sleep apnea surgery. Well, I come from the city, or currently come from the city that never sleeps. And during the pandemic, it actually was a little bit sleepier than usual, but things are back to picking up. I think the traffic is much more back to normal, and people are coming back, and we're back to 100% indoor dining capacities. And I think they're promising theaters and everything to open soon. So anyway, so the sleep disruptions, I think, going to start pick up again in the city. People all over the world are starting to monitor their sleep. They're realizing the importance of quality of sleep, of implications of sleep deprivation and disruption for their health and longevity. And so there's so many gadgets, and there's a lot of money being poured into developing all of sort of Fitbits, like iPhones, iWatches. There's different apps, there's an Oura Ring, and I can't tell you how often people come in and say that, oh, my Oura Ring tells me I have poor, like not enough REM, or I don't get enough deep sleep. And so what does that all mean? So anyway, so people are aware of this. And so now as a physicians, we actually need to be able to manage it and provide adequate care. And I think each individual person needs to be addressed and looked at as its own human being with their individual problems. So as an otolaryngologist, as Dr. Hoermann mentioned, a long time ago, sleep was like just, septoplasty and maybe snoring. But as otolaryngologists, we've actually been involved in identifying and diagnosing airway obstruction related sleep problems since 1970s. And there's a first report that actually talks about how ENT surgery was able to relieve the hypersomnia that's caused by airway obstruction. So it was not until 1980s where CPAP was introduced by the colleagues in Australia. And at that time, it was pretty revolutionary treatment option because it allowed to treat airway obstruction without needing intervention that are surgical intervention and more potentially even morbid interventions. The problem is that not everybody is able to use CPAP as prescribed. And so despite of modifications of the machines, despite of the advances in technology and also therapies that are geared towards improving the compliance with the CPAP treatments, as you can see that over the years, since like 1990s, like to 2010s or 20s, the compliance is still not optimal. There's still somewhere between I guess statistically, depending what statistics you look at, somewhere between 30 to 50% of people continue to use CPAP long term. So alternatives to positive airway pressure or CPAP or PAP are needed. And the treatment needs to be individualized because you have to consider individual patient's disease severity. You have to consider what type of sleep apnea or sleep problems people have. You have to treat patients based on what would be their acceptance of the treatment. Just because CPAP works, it doesn't necessarily mean that people are going to be using it. It's if it's standing on a nightstand, it's not really helpful, So the people actually have to be able to utilize the treatment and be committed to the outcomes. Also, age, anatomy, medical comorbidities are important aspects that need to be considered when talking to people about treatments. And then psychosocial factors. Because some people are so kind of engaged in or kind of obsessed about their sleep that sometimes they think that just treating their sleep apnea is going to resolve their sleep issues and all of their health issues and their social issues. But a lot of times you run into problems when people have other aspects of psychosocial problems that need to be addressed in addition to addressing their sleep. So despite the fact that we've been working on understanding sleep and sleep apnea, we still don't really understand why some people who have no trouble breathing when they're awake, but when they fall asleep, their airway starts to obstruct. And we think about it as a multifactorial mechanism of airway obstruction. And it's not just like weight and anatomy, but then there's also genetics, then there's also muscle tone, then there's age factors, hormonal aspects, craniofacial anatomy. And some of the studies looking at the pathophysiology of sleep suggest that about 56% of people with obstructive sleep apnea have non-anatomic causes of airway obstruction. And that's why sometimes for otolaryngologists, it presents kind of a challenge, like, because we're so focused on fixing the anatomic problems, but then it's only appropriate for less than 50% of people with OSA. One of the things that have been recently introduced is actually looking at the phenotypes of sleep apnea, trying to identify, like, what is the underlying pathophysiology. So we're not necessarily looking at the person like, yes, it's sleep apnea, and that's the sleep apnea is just airway obstruction, just the anatomy. But we're also trying to understand, like, what else is comprising the disturbance of the sleep. And there are 4 different phenotypes that actually been currently proposed. One of them is high passive critical closing pressure, or PCRIT, of the collapsible airway. So that just basically looks at how much pressure is exerted on the airway when it collapses, and contributors to that. And then there's also talking about inadequate response of the upper airway dilator muscles during sleep. Then neuromuscular compromise, and knowing that genioglossus muscle is the primary dilator of the airway, a lot of focus has been paid to neuromuscular tone and inadequate function of the genioglossus muscle. Then also we're looking at the instability of the ventrally control system, and which is considered high loop gain and oversensitive ventrally control system response. And then also looking at the low respiratory arousal thresholds causing premature awakenings in response to the airway narrowing. And so these people actually will be kind of maybe considered more of a light sleepers or more sensitive sleepers. And so they wake up more frequently without even having significant airway obstruction or airway collapse. So implications of that is that if we can understand what is the underlying pathophysiology of sleep, we can actually design or address each individual person in more of a targeted fashion. For example, for high PCRIT, you can offer upper airway surgery, you can do skeletal surgery by advancing, expanding the skeletal structures, you can offer oral appliances to open up the airway, weight loss, positional therapy. In patients with poor response to the upper airway dilator muscles, then there's therapy such as hypoglossal nerve stimulation, myofunctional therapy, and then there are some various medications that are currently being looked at in the clinical trials, trying to restore the neuromuscular tone. In cases of a high loop gain, treatments with oxygen or potentially carbonic anhydrase inhibitors, and then low respiratory arousal threshold hypnotic medications to promote sleep and decrease the increase the respiratory arousal threshold could be useful in those situations. But also, I think that the emphasis I would like to emphasize that some individuals can have multifactorial, as we talked about, problems, and understanding that it could be not just a skeletal problem or weight problem. It actually could be a combination of factors that contributing to sleep disruptions. And that's where the combination therapy, sometimes combining some of the treatment options, would be essential and could be individually designed to improve the outcomes. So when we talk about sleep, we can't talk about sleep apnea without talking about weight. Weight is an independent factor that contributes to sleep apnea. And as weight increases, the probability and prevalence of sleep apnea increases as well. The good thing is that traditional diet and exercise methods are not the only armamentarium that are available to us. There's various surgical treatments for weight loss, bariatric surgery, there's devices, but then there's also medical weight loss treatments. So I personally worked with an endocrinologist and a fellowship trained weight loss person who does look at patients' metabolism and try to understand what is it that contributes to persistent weight gain, and why the people are resistant to weight loss. And in those cases, sometimes people would be candidates for medications that either suppress their appetite or promote their metabolism or else. Various devices that can improve snoring and sleep apnea and can also be combined with other treatment options. And again, sometimes this is something that people find online, they look online. And so I think as physicians, we should be familiar that there are various devices to help people close their mouth. There's various tapes, there are nasal stents, there's chin straps. There's also promotion of devices for positional restriction to help with snoring, whether could be like positional pillows or vibratory devices. And there's also applications on the phone that help people to stay on the side because sleep apnea and snoring can be so much more pronounced when people are sleeping on their backs. Also, dentists have been in the front lines of treatment and diagnosing of sleep apnea. A lot of dentists do they get certifications in sleep apnea management, and they work on setting up people with the oral appliances. And I believe the requirements are actually that a dental appliance should be at least supervised or made by somebody who is specifically specialized in dentistry and is certified in the treatment of sleep apnea. And it could be indicated for treatment of mild to moderate sleep apnea as a primary way of treatment of the disease, or even in the cases of severe sleep apnea, it can also be pretty effective. And there's, again, a variety of different appliances are out there, and depending on the individual patient's anatomy, the dentition, and treatment tolerance. There's also now you're able to monitor compliance with the oral appliance. There's a heat sensor that could be attached to the oral appliance where you can monitor how frequently and how consistent people are with their treatment. As Dr. Carrasco mentioned, the drug-induced sleep endoscopy has been one of the tools that we use in the treatment and evaluation of people with obstructive sleep apnea. It's been popularized by otolaryngologists in the 1990s, and it's become much more prevalent in airway evaluation with introduction of neurostimulation treatment for obstructive sleep apnea. And this is something that we can definitely utilize to further understand what's happening to people during sleep, especially as you can see here, it's the same patient. We're looking at the airway when patient is awake on laryngoscopy, and you can see slight retroflexion of the epiglottis, but we can't really appreciate what's happening to this patient during sleep. And so again, even though it's not a perfect tool, it's still a tool to help evaluate the patient's airway and potentially design some of the more precise interventions and understand why people are not responsive to certain treatment. And you can see that if the person is asleep, you can definitely appreciate some more airway obstruction, specifically at the epiglottic level. UPPP or uvula-palatal-pharyngoplasty have been kind of like a workhorse of sleep apnea surgery for otolaryngologists. And at some point in time, people kind of started talking about how this might not be an effective treatment, but with further kind of an individualized approach and looking and selecting people more precisely who could be candidates for surgery, uvula-palatal-pharyngoplasty can be an effective treatment. And our colleagues in Europe have demonstrated that it can, in a properly selected patient, you can have pretty significant reduction of apnea-hypopnea index and improvement of quality of life. Especially now, there are a lot of modifications that have been introduced to treat patients with obstructive sleep apnea who might be candidates for palatal surgery, and with modifications that are geared more towards not necessarily just removing the tissue, excising the tissue, but actually expanding the airway, repositioning the muscles, and changing the more of a function of the or nature of the obstruction versus trying to just remove tissues. Those procedures have led to even more improvement of the procedure outcomes. Transoral robotic surgery was introduced and then was expanded into the treatment of obstructive sleep apnea. And again, improperly selected patients who have specifically obstruction at the base of tongue. And this could be an effective treatment if, again, selected properly. And this is, again, some of the technological advances that allow us to provide more of a multi-level surgical approach and address people's problem on more than one level. Again, and then another thing that I briefly touched upon earlier, that drug-induced sleep endoscopy allows us to, again, to further evaluate what's happening to people during sleep. And in this case, I think we've been always underappreciating how much epiglottis can contribute to the airway obstruction. And you can see that in this case, the patient has pretty much isolated epiglottic obstruction, which makes this person pretty miserable, makes her very intolerant to CPAP, and then correction of that obstruction can potentially improve her quality of life or potentially improve the tolerance of other treatments such as oral appliance and CPAP. One of the more newer approaches, again, looking at more of a neuromuscular tone issues and neurophysiology of airway obstruction during sleep, understanding of the anatomy of the hypoglossal nerve allows us to now address, sleep apnea without necessarily changing the anatomy or specifically targeting the anatomy. As I mentioned earlier, genioglossus muscle is the primary dilator of the airway, and hypoglossal nerve innervates the muscles of the tongue and also specifically genioglossus muscle. And so this became a very attractive target for treatment of obstructive sleep apnea, because by just stimulating the nerve, providing neurostimulation, you can actually advance the tongue and open the airway and re-engage the muscles of the airway. So specifically targeting the part that innervates the protrusor muscles, and which is more of a genioglossus muscles, the medial branch of the hypoglossal nerve, that's been an interest of current neurostimulation therapy, as opposed to trying to avoid stimulation of the muscles that retract the tongue and obstruct the airway. There's a couple devices that have been currently introduced and available on the market. Some of them, the one that's actually been used in the United States and in Europe, that's actually available on both continents. That device is an implantable battery that gets implanted under the skin, connects to the right-sided hypoglossal nerve, and it monitors the breathing patterns with the breathing sensor, delivers information to the pulse generator, and then that in turn stimulates the tongue, muscles of the tongue with each inspiration. Early version required 3-incision approach, but recently FDA approved the 2-incision, and so now the device can be actually inserted through 2 incisions, and the breathing sensor lead that used to be inserted through the 3rd incision now gets inserted through the same incisions as a pulse generator. And that has saved significantly on time that's required for implantation of the device. I also introduced a little bit of a modification for female patients, and I do put the incision a little bit more laterally to allow for more better cosmetic or plausible cosmetic outcomes. And here's the anatomy of the nerve that you see intraoperatively. You can identify the medial and lateral branches, and that's where you try to target this part of the nerve where that's what you want to place your cuff on to allow for unrestricted forward protrusion of the tongue. Another device that's currently in the clinical trials in the United States, and there are several centers that are currently recruiting patients for that. It's currently available in Europe already. This device actually targets both hypoglossal nerves, and it's implanted under the chin through 1 incision, and has an external battery. So battery gets attached externally under the chin to stimulate the bilateral nerve, and that allows for the opening of the airway. And you can see there's a small incision under the chin, and that's where the device sits specifically on both nerves with the electrodes attached to both nerves, and that's and the external battery gets taped to the chin every night and is used for management of sleep apnea during sleep on patients. One of the other things I want to mention that there's also phrenic nerve stimulation implants that are currently available, but those are not implanted by otolaryngologists, but again, add like a little bit extra armamentarium to the treatment options or treatment algorithm, because you can also manage central apneas by using implantable nerve stimulator. And that's implanted usually by cardiac electrophysiologist, and that procedure is very similar how they do the implantation of the pacemakers and other cardiac devices. And the electrode sits right next to the phrenic nerve, and stimulation could be provided, which kind of to synchronize the breathing patterns in patients who have central apneas. So as otolaryngologists, we're actually very well positioned to provide multidimensional and comprehensive management of sleep apnea. We can screen the patients, we can provide diagnostic airway exam, including drug-induced sleep endoscopies. We can do sleep studies, whether it's in lab or home sleep studies. If we are board certified, we can read them ourselves, but we can also refer patients for that and then interpret the studies. We can prescribe positive airway pressure treatments. We can also guide patients towards the oral appliances. And again, nobody is better than otolaryngologists in providing surgical interventions, and especially if we can provide them in a targeted fashion. And I think now with neurostimulation option as a treatment, we actually expanded our reach in terms of patients and ability to provide effective treatments even further. And again, we can follow the patients and guide them towards either single or combination therapy. So individualized approach is needed to achieve optimal sleep apnea therapy. The therapies and technology continue to evolve and improve, and one-size-fits-all approach is no longer effective and fails a lot of patients. So I think we should consider different treatments. We should actually look at people individually, and sometimes combination treatment should be an appropriate approach. As poor treatment adherence does not provide benefit neither for patients nor for us. So thank you again, and I will stop sharing right now. Thank you.
Thank you, Maria. It was excellent and very conclusive. And we continue with Ahmed Bahgat. He is professor at the University of Alexandria and president of the Egyptian Laryngological and Sleep Society. And just add, I said it before, with the sleep apnea friends with 300 WhatsApp stories every night. He's one of the busiest one. So please start with your presentation.
Thank you so much, dear Professor Hoermann, for your kind and honorable invitation to be here among my great friends and professors in the American Academy grounds. I'd like to thank also Dr. Muaaz Tarabichi for organizing such international grand round. I'm going to talk about a specific surgical technique on the palate, on the oropharynx, that we use coblation and barbed suture in order to widen the space behind the soft palate. As Maria and Marina said, we don't now perform the same old UP3 like before, but we are shifting to widen the lateral wall of the pharynx in order to gain more space and reconstruct the soft palate and pharynx to avoid palatal collapse. I did record my presentation to avoid any problems in internet connection, and Elise will share the video now. So I'm asking her to do that, and I'm available and online at the end of the session to answer questions also. Thank you so much.
Dr. Ahmed Yassin Bahgat. I'm consultant of sleep surgery at Alexandria University in Egypt, and I'm honored to be son of Professor Yassin Bahgat. Thanks so much, my dear father and professor, for your continuous support and your continuous teaching. I'd like to thank also my father to introduce me to Professor Claudio Vicini, my second father in Italy, and all his team in Morgagni Pierantoni Hospital in Forlì, Italy. I have nothing to disclose. I have no conflict of interest, and I have no commercial benefits from the companies I'm going to mention in my presentation. So coblation means controlled ablation. It's a chemical process. It's not a thermal process. We don't generate heat so that we cut tissues by heating tissues, but it's a chemical process by producing energy at the WAN tip, and that energy dissociate the saline, that is water and sodium chloride medium, that we call the conductive medium, to produce what we call excited plasma. What is excited plasma? So you can find the yellow color of the sodium. It's not the heat like the yellow color you can find in the tip of the bovie. And you can find the vapor. It's hydrogen and oxygen atoms coming out from the dissociation of the saline. It's not again a product of heat, and you can find free radicals at the end, and that free radicals they separate the bonds between cells and we dissociate tissues, so that you can cut tissues by simply making that chemical reaction. With coblation, you can find production of heat, but it's a byproduct heat. So the heat coming out from the electrocautery is 800 degrees Celsius. The heat coming out from the laser, it's about 400 degrees Celsius, and the heat coming from coblation is about from 40 to 70 degrees Celsius. So here is the coblation technology and how it works. This is the excited plasma, and it removes cells layer by layer by removing one layer of cells. So you can ablate tissues like that. Whenever you have bleeding, you can apply the coblation wand at it, and you can make coagulation of the bleeder, so you can reach a bloodless field. Very gentle manipulation of tissues, very minimal penetration into surrounding tissues. So when we compare coblation versus electrocautery, so you can find this main advantage, that very low heat coming out as a byproduct. So we say always, when you drink a cup of tea, it's about 100 degrees Celsius. So coblation is cooler than drinking 1 cup of tea. So gentle removal of tissues, gentle minimal tissue dissolution. So it's very minimal thermal penetration. Here's the coblation wand that we use in our technique, in the co-barbed technique, the EVAC 73 Extra, the high power one. Its tip is 3 active electrodes to produce energy that will make the excited plasma. And the HP version is 30% longer electrode life compared to the ordinary one. So we use it, and the wand contains irrigation coming out from here with the saline coming out here, so that the energy will interact with it, and a suction also at that tip. When we revise the pathophysiology of obstructive sleep apnea, we can find that here is a normal individual. He can breathe through the nose and mouth, and here's what happened in obstructive sleep apnea. We have obstruction here at the level of the palate and at the level of tongue base. We used to use coblation in very minimal application in the CAUP technique, the coblation-assisted upper airway procedure, and we applied coblation wands as a needle to produce stiffening and channeling of the upper airway above the tonsils and in the uvula and in the soft palate. But this is a minimal procedure. We used to do a midline procedures at the level of the palate, like uvulectomy, radiofrequency, UPF, and pillar implants, and palatal stiffening with coblation. But now we shifted the palate surgery pendulum from working on the midline to work on the lateral part of the pharynx, and so that we can work on the palate secondly. So here what we call the lateral wall dressing techniques, the lateral pharyngoplasty and its variants. And the advantage of doing that we have main vectors of enlargement, that we don't have no scarring, no volume enlargement. We don't remove tissues to increase the space, but the main lateral vector of enlargement here. So the more scar is the more lateral and superior and anterior widening of the pharynx, and hence the more stretch of the soft palate, unlike the previous UPPP. Look at that. This is the previous techniques we used to on the level of the palate, central part of the palate, and here's a scar in the midline here. It makes the tissues come toward the midline, but here is the scar on the lateral part of the palate, and the scar is working with you to widen the pharynx. Here's the main idea of doing reposition pharyngoplasty by taking the palatopharyngeal muscle from the lateral pharyngeal wall and relocate it anterior, superior, and lateral toward the pterygomandibular raphe, and so that widening of the pharynx and hence stretching of the palate. So here's the first technique, doing co-barbed pharyngoplasty by doing coblation tonsillectomy. As you can see, the evac wand, we use it. We almost bloodless field. We keep in close contact with the tonsil. We remove the tonsil. We preserve every single millimeter of the mucosa and the posterior pharyngeal wall. And I advise you now to do, when doing coblation tonsillectomy, to put this piece of gauze on the posterior pharyngeal wall and to put another piece of gauze over the uvula like that to protect them from being sucked and being ablated unintentionally, definitely, while doing coblation tonsillectomy. Then we start to prepare the palate before suturing it. Here's the idea of the fat pad, supratonsillar fat. It's found by or written by Dr. Tucker Woodson and Dr. Stuart McKay. So they found that above the tonsil we have a pad of fat that we call it supratonsillar fat or lateral palatal space. That pad of fat is another obstacle between the palatopharyngeus muscle and pterygomandibular raphe. So after removal of the tonsil, we have to remove that fat in order to suture it, the muscle toward the raphe directly without any obstacle. So again, here's the maquette in courtesy to Professor Claudio Vicini. Here's the palatine tonsil and here's the supratonsillar fat. And after removal of those obstacles, we can suture the muscle to the pterygomandibular raphe. Here is the palatal preparation. We cut just weakening of the palatopharyngeus muscle inferiorly, not complete cut, just weakening of the muscle. And then we ablate the supratonsillar fat with the tip of the coblation wand layer by layer in a bloodless manner until we remove the whole fat above the tonsil. Sometimes the fat, especially in tonsillectomized patients, especially in obese patients, can find a very big bulk of fat to remove. And then we mark the barbed pathway with the coblator. We use the coagulation mode on 3, and we just put 3 main points. 1 point at the posterior spine at the junction of the hard and soft palate in the midline, and the 2 other points in the midway between the midline and the pterygomandibular raphe at a lower level. So it's just to make the suture to pass from here to here without significant bleeding at the mucosa, and then again from that point to the raphe, and from the raphe to the muscle, to take the muscle superior, lateral, and anteriorly toward the pterygomandibular raphe. What kind of suture do we use? We use the barbed suture. We use the V-lock suture. We use 3O suture with a needle, 26 millimeter needle, and we don't have the bidirectional needle, especially in that V-lock system. So we make a knot in the midline and we make the suture a bidirectional one. Why to use V-lock versus the Stratifix one? Because the V-lock have more barbs, more strong spiral barbs, and when we apply that kind of traction over the sutures, you can find that the Stratifix one is weaker than the V-lock one. So the V-lock one can stay in tissues and can hold tissues in a stronger manner than the Stratifix one. That's why we started to use now the V-lock one. It's better, especially in obese, in strong persons, and we use it in the palate, and it's a very mobile structure during eating, during speaking, and during drinking even. So that's why we use the V-lock suture. First, we applied the first pilot study in 2015. I'm honored to be among the authors of that paper, and then we studied it in a multi-center study. And that paper was published in 2017 in Clinical Otolaryngology, and Professor Claudio Vicini and his team published also the effectiveness of barbed position pharyngoplasty in a prospective randomized trial, and that's very important to provide an evidence to that technique. It was published in October 2019. Here's the summary of the technique. After preparing the palate and after doing tonsillectomy, we start from the midline here, and we keep pulling the suture until we reach the midline between the 2 needles, and we go to the midway point and then to the pterygomandibular raphe, and we take the muscle. First suture, we take two locked runs of sutures, and then we take the muscle toward the pterygomandibular raphe. We repeat that manner many times, at least 3 runs of suture from the muscle to the raphe until we fix the muscle to the pterygomandibular raphe. We take one suture on the right side and another suture on the left side. Again, the first suture is locked suture, and then the second suture is it's not needed to take 2 runs in the further sutures. Again, we keep taking many sutures until you can see the edges of the wound is almost closed. And again, don't apply traction or big tension on the sutures in order to keep them in place without breakdown. And at the end, after taking a lot of suture, you can imagine how much time we saved by doing the barbed suture. It's very rapid, very quick technique when we compare it to the other techniques. And then we take one suture from one raphe to the other raphe in order to keep like that bridge to support the palate away from the posterior pharyngeal wall. And again, the same on the other side from one raphe to the other raphe, and then we cut the suture. Here's the picture at the end of the procedure. Here's a picture of the preoperative endoscopy. You can see that there is collapse of the palate, especially here and the lateral part of the palate. And at the end, you can see how the palate is elevated, and how the retropalatal space is wide, and how the posterior pharyngeal wall and lateral wall of the pharynx is well suspended. So we didn't touch the central part of the palate as you could find in the video, and but the palate is well suspended superiorly and laterally and anteriorly. Here's a picture after 1 month, and here is a picture after 4 months, and here is a wide retropalatal space. What about the future? We are waiting for the hollow wand of the coblation. It's very fine and very delicate in repositioning tissues. I could find that wand in last Orlando meeting in 2020. And as soon as it's available, we are going to use it in doing the version 2. Thank you so much, and please stay safe, and see you very soon.
Thank you very much, Ahmed, also for all 3 speakers for keeping in time. There was a comment from author to Maria. You should also address that ENTs can also prescribe oral devices or oral appliances. Do you agree? You have to demute you. Yeah.
Sorry. Yeah, so otolaryngologists actually been playing a significant role in prescribing and setting up people with oral appliances as well. So I think a lot of us, we see that majority of dental appliances still being fitted by the dentist, but otolaryngologists have been looking, expanding their expertise in the oral appliances as well.
Then a question to Ahmed from Qureshi. Does this technique affect the quality of voice?
Actually, no, because we don't touch the central part of the palate, so it will not affect the pronunciation of some palatal sounds like kha or j. So it does not affect the quality of voice at all, because we don't touch the central part of the palate.
Another question also from Quateshi, is V-lock resorbable?
Yes,
it's
resorbable. PDO, yes, it's resorbable after it loses its.
Yeah, continue.
It loses its tension after 90 days, and it's completely dissolved in the tissues after 180 days, after 6 months.
And then also offer writes the surgical video played too quickly for the audience to understand the steps of the barbed suture passes. Perhaps show it again. I want to address that you can see all the presentations after. So step by step is possible for all the participants of the grand round. So there is no need to speed up. You can repeat it later. And then a question of Munzer or Manzer. In a simple snorer, can this technique also be beneficial? Ahmed? Simple
Yes,
snorer.
yes, we do that the same. Yes, in simple snoring also. Sometimes simple snorers they have big tonsils. Sometimes after removal of the tonsils, so we can just pass the suture. We don't need to make a lot of interventions, a lot of turns around the muscle. So it's the same idea, but with less invasiveness for simple snorers as well.
Is it possible to suture the palate like how you did without using barbed suture?
Yes, some colleagues do the same with the vitral suture. So they start the suture from the pterygomandibular raphe downward to the tonsillar fossa, and then they take the muscle and they come back to the raphe in 3 sutures. And then after that, they tie the whole sutures, all 3 sutures at the same time. So they have 3 suture knots at the pterygomandibular raphe. You can do that, but we found that barbed sutures stay a longer time in the palate and in the pharynx. They are not easily absorbable with the saliva like the vitral sutures. So you can do the same technique with other sutures, but barbed sutures are better.
And you save
and
time.
Quicker.
Quicker.
Yes, quicker. Yes, save time. Yes.
And then please share your experience for preventing aspiration after carried out UPPP. Thank you, sir. Good question, huh? Preventing aspiration after UPPP.
Yes. My experience when you perform a multi-level surgery, palate surgery, tongue base, and epiglottis, when you perform 3 surgeries, and of course, if you add nasal surgery, very high probability of aspiration. But if you are going to perform a palate surgery or aggressive lateral pharyngeal wall procedure, we don't recommend to do epiglottic surgery or tongue-based surgery at the same time, because very high probability of aspiration. So it's better to stage the surgery in 2 settings. And I also don't like to do epiglottectomy to remove part of the epiglottis at the same time with doing any kind of palate procedure, because also high risk of, but we perform epiglottopexy. We just induce fibrosis between the epiglottis and the tongue base to decrease its collapsibility. So.
And Maria, that's my question to Marina and you, Marina. The DICE is a wonderful tool to predict the success of neurostimulation. And in my old man point of view, neurostimulation is now like cochlear implant 20 years ago. It will open the door for ENT, also for difficult cases. Can you, both of you, speak about the concentric collapse and the AP collapse in the indication for any kind of neurostimulation in DICE?
Maria, please, you have experience with the 12 nerve, I don't.
Currently, the indication for neurostimulation devices is actually absence of complete concentric collapse at the velar pharynx, and which I think is very great that Dr. Bahgat, he presented such a great presentation on palatal surgery, because some of the techniques that he discussed can potentially fix that complete concentric collapse and allow for people still to qualify for multi-level kind of a combination surgery of pelvic surgery with neurostimulation. One of the things that we're actually finding that sometimes it's not just a complete concentric collapse, but also a significant lateral wall collapse at the oropharynx can also contribute and be one of the indications that people might not be as responsive to neurostimulation. So so there are also techniques of expansion surgery of palatal-pharyngoplasty or expansion palatal-pharyngoplasty that allows to also address those lateral wall collapse. So and there's also interest to see that whether complete concentric collapse is a true contraindication or are there other factors that contribute to it. Current exclusion of complete concentric collapse from neurostimulation is based on a very small cohort study, case study that basically just looked at 20 patients, and they found that about 5 people who had complete concentric collapse were just not responders. And so now we're basically basing it on that data. And so I think more data is needed to truly understand correlation between neurostimulation and non-responsiveness or being a responder to neurostimulation and other factors that contribute to that.
Okay, now really difficult. Yeah, Marina, yes.
If I may add, I want to add something to what Maria said. When we see a very important lateral collapse, we also have to think about the if the palate is very narrow, because when the palate is very narrow, all our techniques are going to be failures. And I think that the group of Stanford is doing now, especially Stanley Liu, a great job here, potentiating the dome technique and the expansion of the palate in order to be better breathers from the nose, and also to expand the palate and have better success, because we have to think on the bone too. Just that.
A very interesting question to Maria, I think. What is the incidence of muscle nerve device failure? Any difficulty in swallowing due to implanted device?
So yes, thank you for this question. We didn't really have time to go into all the details about neurostimulation and all the complications, potential complications and benefits associated with it. So the complications rate in general with implantable devices is extremely low. I have not seen nerve injury or any kind of muscle injury as a result of device implantation. There's some few reports of temporary tongue weakness after the implant. With the breathing sensor implantation, there's a possible risk of pneumothorax, which again, incidence is extremely rare. There are some device failures. Again, we're dealing with implantable technology, so devices can fail, they can break. And again, incidence is extremely low. But there are revisions that can be required for either pulse generator malfunctioning, or sometimes the breathing sensor lead can malfunction or break. There could be a current leak. So in those cases, the revision might be needed, but again, most of the revisions can they're pretty well tolerated and also carry a pretty low complications rate. So overall, of all the surgical procedures that we offer compared to palatal surgery, base of tongue surgery, maxillomandibular advancement surgeries, I think neurostimulation devices actually carry the least morbidity when it comes to treatment.
Okay. A question to all three of you from Greet Gavers. OSAs in elderly, will you perform investigation for apnea, I think surgery, in patients more than 80 years? Will they still benefit from non-CPAP or surgery?
I can start.
If I'm 80 years of age, would you also do the same evaluation as you do for a 50-year-old guy? And my BMI is 25, and I'm 80 years old, and I suffer from, I don't think that I could suffer from OSAs if I have a BMI of 25.
Well, so actually the prevalence of sleep apnea increases as people get older. And I think there's some evidence that patients above the age of 65, the prevalence of sleep apnea is somewhere like almost like 50% or so. So there's much higher prevalence of sleep apnea in elderly. And I think the factors are hormonal changes, neuromuscular tone, like, so it's not always the weight that's a problem when with aging. And just because you're 80 doesn't necessarily mean that you're, people now live like way into their hundreds, and a lot of times you can have a very healthy 80-year-old, and you can, there's age alone is not a contraindication to treatments and to surgical intervention. Would I offer people like, skeletal surgery for like above the age of 65? I'd probably be a little bit more hesitant just because of like, non-union and non-healing and trouble with like, with the bone union. But and also like, soft tissue surgery, a lot of times like it's not the tonsillar hypertrophy, it's not the bulk of the tissue that's contributing to it. However, neurostimulation devices are actually quite effective in people who are older. And there's actually evidence that people who are responders to neurostimulation devices tend to be women, tend to respond a little bit better, and also people like older people tend to respond better to neurostimulation devices, specifically if they're not overweight. So I would definitely do evaluation of people, especially if sleep apnea is affecting their quality of life, and offer them either a positive airway pressure or do the further evaluation to see if they're candidates for neurostimulation device.
Sorry to all of you, we have to finish now, but the discussion is not ended. You can send your question and answers to all of the panelists or individuals, and they will answer you in the next days. No problem. And so I give it back to Pavlo Stolovitsky. Thank you for your excellent presentation and the vivid discussion. We have on at least 50 questions online. So you have work for the next days. Thank you very much.
Thank you so much, Professor Hoermann, for a great panel. And I thank you very much to all the panelists, Dr. Suurna, Dr. Carrasco, and Dr. Bahgat, for your excellent contributions. And I'd like to invite all of you to the upcoming virtual global grand rounds, August 21st. We will have the update and endoscopic ear surgery. And November 20th, we'll do thyroid cancer, new treatment paradigms and technologies in 2021. As Professor Hoermann mentioned, all these grand rounds are recorded, and you can get these recordings through the Global Grand Rounds in otologic.org, and they are available to you for free. You can also get your certificate of attendance for this presentation in the same website. And as Dr. Deneni mentioned earlier, we are going to have a live meeting in Los Angeles. That will be October 3rd through the 6th. And that will be an outstanding meeting where we're going to celebrate the 125th anniversary of the American Academy of Otolaryngology-Head and Neck Surgery. We also have another treat, that the Pan American Congress of Otolaryngology will be hosted by the American Academy of Otolaryngology in Orlando, Florida, the Royal Caribbean Hotel, June 25th to 27th, 2022. The website is panamorl2022.org. You can go in there and send us your email, and we will update you with information on registration, faculty, etc. And with that, I thank you so much for attending these Global Grand Rounds, and we hope to see you soon, live or virtually. Have a good day. So long, everybody.
Bye-bye to everybody. Thank you very much.